Shall now continue our discussion describing the societal impact of fairness, machine learning in healthcare. Consider the long-term impact of fair ML models. We start with the question, under what circumstances does fairness criteria promote the long-term well-being of protective groups over the course of time? Because in standard classification settings, such scenarios are not really considered. Uh, so in one research paper, Liu et al., and others, what they did was that they, instead of even considering long-term consequences, they said, well, let's simplify things and even consider one-step feedback models. And how does fairness evolve over time using, let's say, even multiple criteria of fairness? And what they observed was that even if there's scenarios of one-step feedback loop, the common fairness criteria do not promote improvement in terms of outcomes over time. In many scenarios, in fact, it can cause harm um, if we added such fairness constraints to the objective function, while an unconstrained objective function, that did not happen. Uh, One really big problem in assessing such impacts and analyzing them is that models that aim to predict long-term impacts of fairness, they make a large number of assumptions, or even when they don't, the models are brittle. So it's, how should we address this? There just does not seem to be an easy answer to this. To be fair, this is not a problem which is unique to machine learning or AI. In general, long-term dynamics in any systems are hard to assess. So one thing which has been suggested is that use of simulation for studying fairness uh, long term. So maybe that's a way to address this in a structural manner. So in one study, it was observed that the long-term results offered by simulation supports qualitatively different, though not incompatible fairness conclusions from those obtained before. Uh, so that said, similar studies for healthcare-based scenarios, they are just lacking. So we just don't know. Uh, so that's a question that needs to be addressed by the community. On the other hand, so now switching slightly from the technical machine learning perspective to the healthcare perspective, healthcare outcomes are not the results of, let's say, a particular event happening, or in general, that is, unless there's an accident, or something that just happened in the course of a week or a month or even a year. In general, for most health-related events, there's a whole lifetime or lifetimes, because it can be a generational set of events which lead to particular outcomes. So to address health inequalities and better fair outcomes, we need to think of a lifestyle view of inequality. So basically, what are the long-term consequences of unfair decisions which can accumulate over time? Uh, So questions like, what is the cumulative effect of discrimination faced by an individual over the course of a lifetime? Uh, and so we also have to address questions like, what are the effect of discrimination on multiple points of care over the course of decades, and how does that contribute to outcomes? There's a whole body of literature related to physiological effects of chronic stresses related to inequality, so on and so forth. So another really interesting issue is the issue of um, fairness versus privacy in the context of data. So consider the following. So in order to create better predictive models, um, so it's critical to have gathered data regarding minorities, ensure that the data is not um let's say for the minority population subsumed by the normative or the majority populations. Um, so, but here's a conundrum. So if you want to collect more data, then, well, there are issues related to confidentiality, privacy. Let's say if the data is related to some sort of disability or another variable which can be used for discrimination. So there's no easy answers regarding, well, how do we address these? Because if we collect data, then may not be possible to ensure privacy, but if you don't collect data, then we don't have sufficiently good models. So maybe privacy preserving machine learning models with fairness constraints. So that may be one way to ensure that. Then there are issues related to um, generalization and minority classes. Consider the following. In sub-Saharan African countries, so women are diagnosed with breast cancers younger on average than their peers in developing countries. Um, so here's the problem. So diagnostic tools which are trained on mammograms from, let's say, European women, those are usually primed to identify disease in early stages or in older women and not necessarily for younger women. So they are less useful for women in sub-Saharan Africa. Well, again, here's where the conundrum comes. Well, how do we address this? Well, we can collect more data in the developing world, but then there's the issue that it can be collecting data in such way can be used to exploit vulnerable populations um, and may lead to issues or charges related to data colonialism. So collecting data from certain populations and then those populations not benefiting it from that data. Another almost universally acknowledged phenomenon is related to labels or quality of labels. So in the context of healthcare, uh, consider the following example. So in electronic health records, uh, the data may be encoded in a certain way. So the manner in which the data may be labeled. So the incentives may change. So let's say there's a government policy to describe certain thing. It may change over the course of time. Or even more extreme cases, even how a disease may be defined, that may change over time. But that particular change, let's say the change in governmental policy for compensation or disease definition, that may not necessarily show up in the data if they're just labels. Uh, Similar issues also arise in mental health evaluations, physiological and psychological assessments, so on and so forth. Uh, the problem is that optimizing for the wrong labels can lead to biased outcomes, so something to be aware of. So one example is the Braiding Scale. Uh, so this is a scale which is used to measure localized damage to the skin for a condition known as pressure injury. Uh, the problem with this scale is that it's somewhat subjective in nature with high inter-rater variability. So the idea is that the way it works is a patient has pressure injury, and so the patient comes to the hospital, a nurse practitioner looks at the patient, makes the assessment based on certain elements which are part of this scale, and based on that comes up with that you get a number from that scale. But if you have five different nurses, then you are likely to get five different numbers. Um, so model built on that, that's also going to have another really interesting use case comes from this study done by Zayad Obermeyer. So the scenario is that so we have X-ray data, image data. So based on that, we identify patients with severe pain. Um, and so high disease severity according to a human, according to an algorithm. And based on that, so we determine, well, who is the eligible for surgery. And so it turns out that the model, if you look at the model performance, then what we see is that uh, the model does not perform as well for minority populations, in this case, blacks, for people who are less educated. Uh, and so this was somewhat puzzling. So one explanation is that, uh, well, maybe people of color or people with low income or education, um, it's likely that they are likely to suffer from painful con more likely to suffer from painful conditions. However, controlling for all the other factors and having the very similar X-rays, we observed that that is not the case. So what these researchers did, well, they stepped back and asked the following question: well, what does it mean to actually have a quote-unquote race gap in pain? Okay, so what does happen? So somebody complains of pain in the knee, so the doctor orders an X-ray and finds that, well, it actually looks normal. So then the doctor decides that the pain must have another cause. So if that is the model, then maybe that we have to ask even a more fundamental question. Well, how are we measuring that? Well, that's being done based on a particular checklist. And so if we look at the history of how did that checklist come into being, then it actually has its history from 1950s. Um, and so the original study, from the 1950s, literally all the patients came from Lancashire in England. So there's at that time there was not much variability in terms of the background of the people. So it does not take into account the heterogeneity amongst patients, which we observe today. And so because of that, the physicians end up underdiagnosing these diseases. So what these researchers did, well, they instead of using the pain as filtered through the physician, well, what if we actually just train the algorithm on the level of pain reported by the patients? And lo and behold, when they did that, the performance differential actually disappeared across the populations. So taking this at a more abstract levels, we can also talk about normative principles as they apply to ML fairness. So here's the question. So since it's not possible to satisfy every fairness metric, moral and political philosophy are required for our design choices. So a lot has been written on this subject. So there are consequentialist approaches, so which focus on the potential distribution and its effects, and there are deontological approaches which evaluate the distributions based on the rights, and then egalitarian approaches, well, it confer equal rights or shares to every member of the population. So these are the different ways to think about these problems. And the side of deontic justice, so we ask the question, it's not just the state of affairs of unfairness that matters, but also what were the conditions that led to that state. So that's where we have to take a lifestyle, or rather lifetime perspective on fairness. That various societal, local, historical uh, factors come into play, and which end up and contribute towards outcomes. So that's why, in order to address such things, we have to take, let's say, philosophical, historical, economical, and sociological perspective. That said, this is to address the more general question of fairness and equity. Having these multidisciplinary approaches, that is necessary. This is not to suggest that uh, that one person, it is possible for one person to have all of these perspectives, but what it shows is that modeling strongly coupled systems is a hard task. Because it's not possible to have a system which is perfect in terms of its predictive power, in terms of its fairness. So sometimes we have to ask the question, what type of inequalities are acceptable? So there are different ways to address this, different philosophies which have asked this question. So there's luck egalitarianism, which asks the question that what kind of inequalities can we allow? So, well, so these are the type of inequalities which result from people's efforts and risk taking and do not allow it in cases where because of brute luck. So let's say skin color, if somebody's born with a debilitating health condition, etc. The other thing, the question that it asks is that the coupled nature of social units, that people choices may be limited because they have to choose because they choose to take care of risks of the sick, elderly, young family members. And this is especially relevant in the current day and age that we live in. These questions and these factors especially come into play when we think about how we have handled COVID and continue to handle COVID. In other words, free choices are not always free. Um, And so that's why there's this need to audit systems to determine how the various stakeholders are being affected. And lastly, highlight the issue of race connection in certain algorithms in healthcare. The idea behind this is that different risk scoring adjustments based on race are made in many healthcare models, which also seep into machine learning models. For example, a spirometer is widely used across the world for diagnosis and management of many respiratory diseases. One problem that it has is that uh, comes with the notion that blacks and white lungs differ, and so it scores African Americans differently from Asians and Europeans. The problem is that this particular notion actually goes all the way back to Thomas Jefferson, who posited differences between slaves and freemen's lung functions. Uh, and so previously, these studies based on spirometers were used to justify differences between Europeans, Asians, and Africans by plantation owners and colonial administrators. And so now the problem is that now that such models, they are part of computer, um, such models, whether machine learning based or otherwise. So as you can see, this can be problematic.